when Jennifer Jackson called me and asked me to do this, she said, Jose, I want you to do something for me. And I said, okay, what is it? She said, you have to say yes first. I said, well, we don't usually do it this way. And I said, well, what is it? And she said, are you going to do it? And I said, sure, I'll do it. So anyway, I'm here. I went to high school with Jennifer, so that that's how she can pick on me a lot. But anyway, I wanted to put everybody here in medical school. I'm going to present a case, and I'm going to talk about something called hopeful leadership is what I titled it. I don't know if that's necessarily the best title, but it's how I deal with kind of hard situations with patients and things that I do. So I'll present this case of Jane Doe. She is a 55-year-old lady, and she was feeling weak, tired, just wasn't herself. She went to her primary care doctor, and her doctor, saw her, did some labs, didn't feel like things were right as well, and did some labs, and she was found to be anemic or have a low blood count. And one of the common causes of a low blood count is blood loss from your intestines. So I'm a colorectal surgeon, by the way, and I don't know if you said that, but that's what I take care of. And so she felt maybe she has a problem in her bowel. So she underwent a colonoscopy. And at the time of the colonoscopy, she was found to have a colon cancer. So her primary care doctor refers her to me in my office. And the first treatment really for colon cancer is surgery. So she comes with her family to my office, gets in the room. My nurse puts her in the room and kind of gets her history and squares away the computer chart that we have to deal with. And then I come in. First thing I always do when I walk in the room with a patient is there's always a lot of people in the room, especially when it's something like this, a cancer. And I shake everybody's hands. I look them in the eye and I figure out what is your relation? How are you related? So I want to know who's in the room. And then I finally work my way. Usually the patient's the closest to the chair that I sit in. So I meet her and we talk about her colon cancer that she had found, and what we need to do for this. Her CAT scan didn't show any evidence of spread. I explained to her that we'll take this part of your colon out, about a foot of your colon, hook it back together. Really, people come to my office with colon cancer and they want to know two things. They want to know if they're going to have a colostomy and if they're going to die. And so I work on the first thing is that we're going to be able to cut out this part of your bowel, hook it back together, shouldn't need a colostomy. And then I talk about the surgery itself, and that we'll remove the bowel, and then we'll send it to the pathologist, and then we'll have the full staging of it so we know more about the disease. I then talk about the surgery, the details of the surgery, and then I talk about the risks of surgery. This is kind of when I start things get a little bit more serious, but I say, hey, I'm going to do surgery on you, and there's risks of surgery. When you do surgery, you can bleed, you can have infections, you can have heart attack, strokes, you can die of surgery. This is serious. And go over all the details, let the family, the patient ask questions, and then we set the date for surgery. So a couple days or a couple of weeks later, we'll do the surgery. At the time of surgery, I meet them the day of surgery. I meet them in the holding area, make sure there's no other questions, and I usually like to leave them with the thought, I say, well, I will take good care of you, and I'll see you in there. So I do the surgery, and I open her up, and she's got the colon cancer, but she also has fine little seeds of tumor cells that's called carcinomatosis, and that's stage 4 colon cancer. So right when I see this, I say, it's not good. She'll more than likely die of this. And so I do what I can do. I take out the colon cancer, do all the biopsies, close her up, go to recovery, and then I call for the family and I meet them in the consultation room. Right when you walk in the consultation room, there's usually, a handful of people, sons, daughters, grandkids, and everybody's looking at you. So right when you walk in the room, they're all trying to figure out what's happened before you say anything. So I make sure I know who everybody is in the room. I sit down and I say, hey, we've done the surgery. I've cut out that section of the bowel. We're going to send it to the pathologist. We're going to learn as much as we can learn about this. And I did find little tumor cells that could not be removed. And for this, we're going to need some additional treatment besides the surgery. You're going to need some chemotherapy. We'll get an oncologist to see you. And I like to, people, want more specifics. They want to know time. They want to know what's going to happen. And, I can't predict what's going to happen. I mean, I have a general idea. But I like to say, under this circumstances, I like to say that, well, when I first came into practice, when somebody has this carcinomatosis, they would live 3 months. Treatment has gotten much better since then, and now you can really measure people's life in years with this kind of problem, with good treatment, and that we're going to assemble a good team of people to take care of you. So I then will talk about the different treatments, and that there's experimental protocols, and there's research at all times going on this subject, and we really don't know what the treatment will be down the road. So at this point, I kind of open the floor for questions and talk to them, and there'll be all kinds of questions. And then I'll leave, they'll leave. Then the next morning I will have the same conversation again with the patient, because obviously I can't talk to the patient today because they're on medications and anesthesia. So the main thing is, when you deal with these kind of tough situations, you can't walk in the room, have your head down, be defeated. I mean, there's tough things to deal with, but you just got to have the right leadership attitude, I think, and it will really help the patient deal with the problem better. So that's just a little bit about taking care of cancer patients and having the right attitude, and not being defeated. And that's what I wanted to talk about today.